One of the major findings of the trial was that this was a very safe and effective treatment for patients with non-metastatic CRPC. It remains a question as to whether or not we have or will develop a standard of care in the non-metastatic CRPC patient population. I think that this further corroborates the use of abiraterone in an early CRPC patient population. It's not quite sufficient evidence, I think, to support a registration in the non-metastatic group of patients. But the reality is many patients with CRPC out there have a relatively low burden of metastatic disease, maybe even a lower burden than we saw in the 302 study in which metastatic disease was required. So this, I think, just further demonstrates the overall efficacy of this agent in the CRPC patient population. I should also point out that the patients who went on to this trial are patients who were at risk for the development of metastasis. Although the average PSA was only 12, the vast majority of those patients had a rapidly rising PSA doubling time, or I should say a rapidly rising PSA. And if one looks at old curves of PSA doubling times, it's easy to see that patients with a PSA doubling time of 3 or 4 months are at great risk for development of metastatic disease in the course of a period of time of 12 to 18 months. And so the fact that we have not yet reached a median time to metastatic progression is, I think, a significant finding.